Lisa Carberg. Welcome to Medical Monday. We are talking with two awesome surgeons today. We're talking about microsurgery, robotic surgery, and hand surgery with Dr. Luccie Wo and Dr. David Colen. Now, first off, we are welcoming in Dr. Wo. Thank you so much for being with us. We got to see you in action, and it was amazing. Welcome.
Thank you for having me. I'm very excited to be here.
Great to have you. So, Dr. Wo, before we start, let's show everybody our report that we came out and watched you in action at Yale. Angela Sutphin is thrilled she can hold her new grandson with her right arm. She is a 2023 breast cancer survivor and had her lymph nodes removed in radiation. Like many women, that led to lymphedema with severe arm pain and swelling.
Lifting the arm was very difficult, so it started affecting me physically because it's my right arm.
These are the tiny tools that relieved Angela's debilitating pain. Dr. Luccie Wo, a Yale medicine plastic surgeon, is trained to use the new Sumani surgical robot.
Yale New Haven Hospital is only the fifth in the country to acquire the Sumani surgical system and the first in New England.
Through a microscope, you can see how using a needle barely visible to the human eye, Dr. Wo sews simulated practice veins together. She operates the robot using foot pedals and what looks like two curling irons, all to connect a patient's lymphatic vessels to nearby veins and allow drainage and relief. Dr. Wo explains that microsurgery like this reduces a surgeon's natural hand tremors, allowing precision. A microscope and 3D view lets her feel like everything is much larger for the lymphovenous bypasses.
The robot is completely controlled by me, but every time, let's say I move 7 centimeters, the robot only moves 1 centimeter. He did about, I think, 5 or 6 lymphovenous bypasses on her arm, and that really gave her a lot of relief in terms of her symptoms.
Angela was thrilled to welcome her first grandchild.
And I was able to hold him and do all the wonderful things grandmas like to do.
Welcome back. So, seeing you in action was really amazing, Dr. Wo. How was it to learn the system, the new robotic system?
Honestly, it wasn't as difficult as I anticipated. The robot is very intuitive to use. It did take a few sessions, some practicing, understanding the limits of the technology, essentially the box, so that I'm not going outside of the sensors. So definitely in the first couple of tries, uh, learning how to just temper my movement so that I stay within the range of the robot and all its sensors so that it can capture all my movements.
What is the advantage of doing robotic surgery over using your hands?
So the robot is able to enhance our ability and increase our precision. Again, the motion scaling that it's able to do, the tremor reduction, essentially makes me even more precise than what I can be with just my hands. Now, if you look at some of the surgeries we're doing, we're talking about errors of less than a millimeter. The entire vessel itself can be less than a millimeter. The limit that I'm able to do is really zero point 0.1 millimeter anastomosis. So just sewing to that degree, having the robot really steadies me and just reduces all that margin of error.
Is it challenging as a surgeon to not be using your own hands?
It definitely is unusual at first, but you very quickly realize that you're still within full control. In fact, actually, sometimes in more control. The robot takes away any surprising movements or any jerky movements. So essentially, in some ways, I feel a little safer because even if I were to, God forbid, have a stroke while I'm using the machine, the patient's actually protected because the robot won't let me do a sudden movement that would harm the patient.
Now, later on, Dr. Colen explains with his hand surgery, he doesn't have the 3D aspect. And using the robot, you get that 3D. Is that hard to adapt to? It gives you that 3D and you're not using your own hands. What is that like?
So the 3D component comes from the microscope, the exoscope. Essentially, what it does, it has two lenses to it, and it's able to recreate the image. And I wear these 3D glasses to have 3D visualization, even though it's on a 2D screen. So I would say that the technology has come a very long way. I've been using exoscopes on and off for the past couple of years, maybe about 5 or 6 at this point. And I think the improvements in the technology is quite significant. Being able to use the exoscope really increases the ergonomics of the surgery. Um, and I think that is very valuable. I would have to say that it is not exactly the same as optical microscopes yet. Optical microscopes, just from the physics, gives us still a slightly crisper image.
All right, Yale plastic and reconstructive surgeon Dr. Luccie Wo. When we come back, we'll talk about what kinds of surgeries you are using robotics for. We are back with Dr. Luccie Wo. She is a Yale surgeon, and we watched her in action on a simulation, and it was totally amazing that, as my report said, the needle was barely visible to the human eye. But, Doctor, we watched you sew with it and perform surgery on a simulator, and you were quite amazing and steady. That was lymphedema that you were treating there. Tell us a little bit about that condition and how you help.
Yes. So lymphedema is a disease of the lymphatic system. The lymphatic system is a similar to our veins and arteries, but it manages what we call interstitial fluid. What it is that is all that fluid that your body builds up and has some waste in it, and it causes swelling if it were to build up. So in a lot of my patients, I treat a lot of breast cancer. My patients have breast cancer. As part of their cancer treatment, they need to take the lymph nodes from their axilla. That's to prevent the cancers from spreading. Now, the downside of that is that it destroys their lymphatic system, and the lymphatic system becomes backed up, especially when they couple this with radiation. Radiation is great for treating cancer. It also still actually damages a lot of soft tissue. So when my patients show up with symptoms of swelling, persistent swelling that doesn't get better with compression, some bouts of even skin infection, I work them up for lymphedema. There's a few imaging tests we do. And then I'm able to offer them a few options for surgery to treat the lymphedema if that is what they seem to have. One of them is something called a lymphovenous bypass. Essentially, the lymphatic system is supposed to be a low pressure system that manages all your extracellular fluid. I'm able to decrease the pressure there by connecting it into another low pressure system, which is the vein. So I connect it. So I find these vessels that are honestly on the scale of zero point 0.1 to 1 millimeter, and I sew them together to little branches of the vein. And that's the bypass procedure that I offer. The other procedure is sometimes we can transplant lymph nodes from one part of the body to the other. So we can take some lymph nodes, sometimes from the neck, areas where that hasn't been treated by cancer, take a few of those lymph nodes and bring them to the extremity that has swelling. That also requires microsurgery. It requires an anastomosis between an artery and a vein. Similarly, I use the robot for breast reconstruction. So for my patients who choose to have microsurgical breast reconstruction, the most common being where we take part of their abdomen um, and with the blood vessel, bring it up to the chest and sew it to the chest.
And doctor, as you're talking, I just want to show that is my hand to give you a comparison of what the doctor was operating on. That is the simulation, the actual piece. This is some raw video, but take a look at how small that is. I mean, that's smaller than a flosser. I mean, that is very, very on a very small scale. So thank you for that. And let's talk about, so we mentioned lymphedema. You mentioned the deep flap, taking the fat from the tummy and doing a
Mhm.
breast reconstruction. What other kinds of conditions do you treat with the robotic, the new
So
robotic
the robot
system?
Yeah, the robot is great. They recently came out with dissection tools, so now we're able to use it to do very precise nerve dissection. So dividing the nerve into intravascular components and being able to be very much more precise in terms of our targeting of nerve reconstruction. Anything that could need high precision, the robot could potentially be a candidate in helping the surgeon perform that surgery. From microsurgical reconstruction, we do it for breast, but we also do it for extremity reconstruction, such as doing salvage procedures for legs, uh, bringing for anywhere you would need a flap, sometimes for chest wall reconstruction, ab wall reconstruction. Those are anywhere where we need that high level of precision.
Has having that robot changed your game as a surgeon?
I think it's given me more confidence as a surgeon to know that I have a tool that can help me um, perform the surgery, just being more precise than I would say I can be naturally.
What is the healing process like with robotic versus standard surgery?
So right now the surgery is still on an open flat platform, so the healing time is about the same between open procedure versus robotic. In the future, the plan is to develop the robot so that it can potentially go into smaller spaces, and then I can reduce the incision size, and that would decrease the healing time.
And doctor, you talked about future technology may also allow surgeons to perform remotely. Tell me about that.
Yes, teleoperation. So that concept isn't new, and it's not just with our current Samani robot, but also with Da Vinci or any surgical robot. The idea is that the surgeon who's operating doesn't have to be in the same room as the patient, since the control is remote. Right now, all surgeons pretty much the standard is we're still in the room, we're controlling the robot. If anything happens, we can unscrub, we can take away the robot and still go revert back to performing everything by hand. In the future, once our connectivity is strong enough, you can foresee maybe a surgery. Telesurgery has been done already, but it's not standard. But then surgeons don't have to be in the same room, in the same city, or even be in the same state or country to perform the surgery. I think that can really level the playing field in terms of access for patients. Some patients who are just in more remote areas that don't have highly trained specialists to perform certain surgeries, having using robots, we may be able to deliver that same level of care to them.
Dr. Luccie Wo, thank you so much for letting us come over and watch you in action. Very informative, and we appreciate your time. When we come back, we'll talk to Dr. David Colen about some hand surgery and some latest cutting edge techniques. Thank you, doctor.
Thank you very much.
All right, we are back on Medical Monday. We're with Dr. David Colen. He is a Yale plastic and reconstructive surgeon with Yale and Yale Medicine. Doctor, welcome and thanks for being with us.
Thanks for having me.
So tell us about your specialty is hand specialty and microvascular hand surgery. Tell us a little bit about what you do in regarding surgery.
Sure. So my practice consists of hand surgery and really reconstructive microsurgery of the extremities. This means really in the hand, typically microvascular surgery entails repairing the very small structures like the arteries, veins, and nerves of the fingers. This most commonly comes into play when someone has an injury to the hand that either amputates their finger completely or at least severs some of those structures. Because the blood vessels and the nerves are quite small, we often require bringing the microscope into the surgical field so that we can really visualize and repair those things under microscopic vision. Most vascular surgery done in the hand requires the microscope. And so really that's probably the most common and most complex thing I do with microvascular surgery in the hand is a finger replantation, which is really after a finger has been completely severed, it can be replaced, provided the structures are not too injured, by repairing and putting back together all the structures, including the vessels and nerves.
Okay, I have to ask the obvious question. If a finger is severed or something like that, how do you keep it usable? So when you get to the ER, you're able to have it reattached. That's amazing.
Great question. The things that suffer from ischemia or really the lack of blood flow most importantly, are muscle. Muscle has a really high metabolic demand, and therefore, when it's absent of oxygen, that it tends to undergo ischemic changes very quickly. Fortunately, in the finger, we don't have any muscle. Really, this finger really consists of skin, the subcutaneous tissue, then tendon and bone, along with the nerves and arteries and veins. So the finger can actually tolerate ischemia for an extended period of time. So what we recommend is putting that finger on a clean dressing, then putting it inside of a bag and putting that bag on ice. We don't want the finger to get waterlogged or to be directly in contact with sub-zero temperatures, so we don't want it to freeze. But really just refrigerating the finger and getting it to us as quickly as possible optimizes the likelihood it can be salvaged.
Okay, information we hope we never have to use, but things like that do happen, as you can tell us. All right, talk about, we were in the OR with Dr. Wo on her simulator, and she had a magnifier, and she had 3D vision with the Samani. What is it like with hands? She was explaining with the surgeon's hand is you can't be as precise as a robot, but what is that like working under magnified conditions with what you do, and performing those amazing microsurgeries?
Well, it definitely requires a little bit of learning to be able to look through a microscope, but focus on what's happening in the field of view, not necessarily directly putting your eyes on your hands when you're operating. But once that kind of learning curve gets flattened and you get used to doing it, the microscope is a very powerful tool. You're able to see every fine detail, and when I'm putting together blood vessels that are sub-millimeter in cross section, so quite small, I'm able to really see every little detail that I'm putting together, which might not be able to be seen really with just loop magnification or with the naked eye. 3D vision also requires a little bit of a learning curve too, but also because you're using, in Dr. Wo's case, using a robot, it's really important to get that feedback to know where exactly the instruments are in space, because you don't get the same haptic feedback that you can feel. So when I'm doing it and looking directly at my hands, I'm getting that three-dimensional proprioception and haptic feedback of where my fingers are in space. But when you're using a robot, it can't really give you that back. So the 3D vision adds that extra bit of information that makes it easier to do.
Very interesting. All right, doctor, what are the most common types of hand injuries? What are they from?
Well, this time of year, especially with weather we've had outside, snowblower accidents are very common. The other common things we see are, slipping and falling on ice, fractures of the hand and wrist. But again, if you're going to be blowing snow around your house and it gets jammed, putting your hand directly into the chute to unclog the jam is the worst possible thing you could do.
How often do you see that in a winter like this?
Probably on a weekly basis.
Wow. So what the advice to people with snow blowers would be, even if you turn it off, does it still have torque? Is that the problem?
Does, yeah. So oftentimes the belt is still loaded, and so you need to probably read the manual and make sure that you've essentially undo or release any torque prior to reaching in to unclog the jam.
All right. Tell us is it easy or hard to come back from a hand injury? How does the hand heal after it's operated on, after it's treated?
Well, that's a fantastic question. The hand itself is such a small structure with so many complex pieces of anatomy in it. And anytime there's an injury, a fracture, especially if you've had surgery, scar tissue will set in. And scar tissue around joints, and especially around the tendons that allow you to move those joints, can cause essentially what's like cementing your joints together, or your tendons to your joints. It causes a terrible amount of stiffness. So hand therapy after an injury is probably the most important part after the surgery itself. So all of my patients, I have a really good relationship with our hand therapists. All of my patients develop very close relationships with their hand therapists because, the easy part is me putting things back together. Oftentimes the hard part is going through the 2 to 3 months of hand therapy afterwards that really is required to get a full recovery.
And doctor, what about sports injuries related to the hand? What do you see?
Most commonly sprains and potentially ligament injuries, especially in ball sport athletes, joint dislocations or at least sprains of the ligaments around the joints, while might not show up on x-ray, commonly can cause a lot of swelling and a lot of pain that can take months to recover from.
All right. And doctor, your advice for people to deal with their hands, to keep them safe? I know that sounds incredibly simple, but to avoid having to see you.
Yeah, so it's really just a matter of, you look at them all the time and you probably take them for granted, but your hands are really the thing that make you able to do everything from wake up in the morning and tie your shoes, brush your teeth. And so really, just have a healthy respect for how important they are and how easily an injury can disrupt your lifestyle.
Excellent. Dr. David Colen, Yale plastic and reconstructive surgeon and hand surgeon, thank you so much for your time and your expertise. We appreciate it.
Thank you, Lisa.